So Dr. Briggs flew in from the East Coast, and we're happy to have her here with us. She's a professor of pediatrics at Albert Einstein College of Medicine and director of pediatric behavioral health services at Montefiore, am I saying that correctly? Good, medical group. And she's done a lot of work concentrating on co-location of mental health within primary care pediatrics. So we're really excited to hear about your work, Rahil. And if you don't mind, we'll go ahead and turn it over to you to share your work and then hear from Dr. Calvin Hobel in just a moment. Thank you, Rahil.
Absolutely. Thank you, Joy. Thank you for bringing me from the East Coast here. But I think have a real advantage. I feel very fortunate to have heard everybody speak already and to get a sense of how this group works and what this group is about, and hope that I can really tie so many of the threads together. As everyone spoke today, I was sort of scribbling notes about things to integrate, and I think that Gabby and Joe and Karen really summed it up best by just speaking about, mental health everywhere, in all settings, for all people, need to be our goal. And there are so many silos that we work within. But the one universal place where we can find mothers, not necessarily pregnant women, and Dr. Hobel will talk about that, but the one universal place in this country where you find mothers is in pediatrics. And I know what people say. I know people say, oh, but pediatricians won't screen for maternal depression, and they say that's not my patient and that's not my training, right? They're right that it's not their training, and that's where we come in. But in terms of it not being their patient, I want to share with you our last decade of work at Montefiore. And I'll frame it really, I'll speak a little differently than I was planning on, because I really want to frame it in a way that's useful to you, to let you know what lessons we learned, and then get you to where we are at the end. To give you a bit of context, the Bronx is a borough of New York City. Obviously, we have about 1.5 million residents. And 40% of our children live in poverty. 76% of our births in 2013 were to single or unmarried women. 50% of our community is Latina, 35% African American, and the rest is usually the most recent immigrants to New York. So it changes every 5 years. It could be a lot of families from Bangladesh, and then there's a lot of families from Albania. Point being, the folks with the least resources and the least social support. There are 62 counties in New York, and we rank dead last on most health outcomes. We're highest in obesity, we're highest in pediatric asthma, we're highest in all sorts of things where you don't want to be number one. So we have our job cut out for us. And if I do my job right and my colleagues do their jobs right, we're going to change those numbers. But I just want to give you a sense of where we're working. Because I hope what you take from this after I sort of tell you what we've done is that if we can do it in a place like the Bronx, we can do it anywhere. So remember that as why I told you all those grim statistics. Montefiore Health System is a gigantic health system with 6 hospital campuses and so forth. My job is I'm the director of pediatric behavioral health services in our primary care network. So it's ambulatory outpatient care. We have 21 practice sites all across the Bronx, so right there in communities where folks live. And we take care of about 300,000 distinct patients every year. So to give you a sense of the scale. About 1/3 of them are children. So I've got about 100,000 children in this network that we take care of every year. And 35,000 of those children are birth to 5. So big numbers and a big system. In 2005, 10 years ago, we started out integrating early childhood mental health in one of the 21 sites. We did universal screening for social emotional development for children ages birth to 3. We expanded that to a second site a few years later, a third site a few years later, and I'm thrilled to tell you that in 2014, Montefiore invested the money to create a fully integrated behavioral health system within primary care across the lifespan. So for all 300,000 of our patients, whenever you come in, wherever you go, whatever practice site you go to, whatever doctor you see, if it's OB, peds, internal medicine, family medicine, I don't care. If you're 1 month old, 2 months old, if you're 100 years old, there will be integrated behavioral health that accepts your same insurance, that provides you with reimbursement for transportation, et cetera, et cetera. How did we get there, and what are the lessons that I've learned that could possibly be helpful to you? I think hopefully is a good use of my time here. The number one most important thing is the need for a champion, and a need for a champion inside the system that you want to integrate into. Apologies for the bad grammar. You get what I'm saying. You want to bring your services into a system. You want to partner with another system. Find a champion in that system who speaks your language, understands what you're trying to do, and will advocate for you when you're not there. Because by definition, you can't always be there yet. You're not in that system, right? Find your champion. And how do you find that champion? And then how do you do the extra convincing that the champion needs to be as excited and as passionate about the work as you are? I like to think that we can convince people on three big, the three-legged stool. Well, here are your three legs. Number one, most people like mothers and children to be happy and well. Most people. Not everybody. It's not on top of everybody's list, right? All right, fine. So for that next group of people, they love science. And you've heard a lot of science this morning. I think Dr. Halfon, I was joking with my table mates, sort of gave you a lecture on anthropology, on brain development, on return on investment, on the economics, on toxic stress, right? We know the brain science is there. We know it from the ACEs study, and we know it from other studies, that what happens in the early years of life are infinitely important for children's development later on. So you've got the bulk of people who like women and children and parents and families to be happy. You've got another subset of people who don't put that at the top, but they put science at the top. And if you can't get them with people being happy and with the science, you can always get them with the money. Untreated mental health problems are the largest cost driver of our incredibly out-of-control healthcare system. And the return on investment when you intervene early is extraordinary compared to intervening later on, right? So that's my three-legged stool for how you find your champion. Do those arguments resonate? And then how you convince everyone else within your system. Once you've found your champion, then what do? You've got to rethink how you package things and what your metrics are. I'm a child psychologist by training, but I work in a medical system. And if I come in talking to all my medical system leadership about attachment theory and those things that we all know is secretly at the heart of everything I'm doing in there, but they don't need to know that. I can tell them it's about cortisol. And that really resonates, and then we get along, and then behind the door I do some attachment theory work, right? Because we're all getting to the same end goal. But if I come in with my big ego and nope, I'm a psychologist and we're focusing on attachment, that's not the language they speak, right? Metrics are critical. Measuring what you do is critical, and it's not as scary as people want to make it out to be. You don't need to be some fancy researcher. Before you go into that system where you're going to cause great change, measure how it's working before you got there. Do people like it? How much screening is going on? How many people are getting connected to services? And then measure it again 6 months later, right? Metrics are incredibly, incredibly powerful. And I'll leave you with sort of what our practice model looks like. So the lessons we've learned, and then I think the final lesson we've learned is what we think is our best practice model. So I'll leave you with that. At every newborn visit across our entire system, both parents or whomever is available as the caregiver receives an ACEs screening when their child is a few days old. We ask the parents for their own ACEs score, and then we ask them to tell us their child's ACEs score. And their child is 4 or 5 days old, and you say to me, well, what do you mean? The kid's score is obviously 0. Unfortunately not, because if you remember what those 10 questions and categories were, if your parents are separated or divorced, you've got 1. If you have a parent who's incarcerated, you've got 2. If you have a parent with a mental illness, you've got 3, right? And we do this for 2 reasons. We ask the parents their own ACEs to try to make a good educated guess at which children are at risk for anything, for developmental challenges, for abuse, for social emotional problems, for parent-child problems. And then we ask about the child's ACEs because by definition, no matter how bad it is, mom's ACEs is higher than baby's ACEs. And that's a wonderful, concrete way to provide some hope in that moment and say, all right, what we're about to do, what we'll do together is keep baby's ACEs at 1. Yours is 7, and you have a sense of how hard that's made your life, and let's keep babies at 1. We screen for maternal depression in all of our primary care pediatrics clinics at the baby's 2-month and 24-month visit. We screen for child social emotional development at 24 and 36 months. We screen for autism at 18 months. We screen all school-age and adolescent children annually using the PSC, which is a patient symptom checklist that screens for internalizing, externalizing, and attentional. And all adults are screened with the PHQ and the GAD-7. And there's also a couple of craft questions about alcohol use. Our behavioral health teams are psychiatrists, psychologists, and social workers. Within primary care pediatrics, we have psychologists and psychiatrists whose only job is to treat the parents. That took about 5 years to win that battle, and most people said, but those aren't the patients, they're adults, they have to go upstairs. And we said, but some of your mothers in here are 16, right? So then that question goes away. Then they said, well, you can't document this in the baby's chart. Fine, we'll open a chart for mom, right? I always suggest that when people say to you, well, that we can't do it because that's just not how we've done it, that you ask as many questions as you can, that you be as unirritating of an irritant as you can be. And we now have adult mental health services. We call them parental mental health services in primary care peds. So mom gets to walk into the pediatrics clinic, which doesn't have a stigma. It's positively stigmatized, if anything. And she just gets to present to the front desk like she would. And she goes back into the patient care, and she ends up seeing her psychologist or her psychiatrist, right? So we're trying to take away those barriers that Marguerite so wonderfully outlined in terms of stigma and the name on the door. Nobody wants to go to Network 180, but people go to the pediatrician, right? And our treatment model for the birth to 5 children falls into 2 buckets. Based on the parents' ACEs scores, if we think of families particularly at risk at any point during the first 18 months of the child's life, we enroll them into our intensive services program, which means that every single time they come to the pediatrician, which anyone with a small child knows is all the time, even if the child's healthy, they see the pediatrician and they see their Healthy Steps specialist. It's a Healthy Steps model, which is a national model, and that person's either a psychologist or a licensed clinical social worker who's paying attention to the parent-child relationship, the parental mental health, the attachment secretly, again, and the development. And then the other bucket where we think that the kids aren't quite as at risk, remember we're in the Bronx and so risk is fairly ubiquitous, but if we think we're not quite as at risk, then we're simply doing ongoing screening and warm handoff in the moment consultation as needed. So they come in for the 2-year visit and there's tantruming, then we go in as part of that visit. And the maternal or parental mental health services are interspersed throughout all of our primary care practices. I think what I would leave you with is the idea that everyone agrees we have to change healthcare in this country, and I think that we need to no longer just accept as sort of, oh, well, pediatricians aren't going to screen for maternal depression, and nobody's going to screen for ACEs, and it's just not going to happen, and so we've got to go out and reinvent the wheel and do all these things outside of the main systems. 98% of children in America have a primary medical home. That crosses all socioeconomic statuses and all races and all ethnicities. We need to be there. That's where the children are, and by definition, that's where the mothers are, and that's where the parents are. And if we go there, they will screen, I promise you. We do tens of thousands of screenings a month. They will screen if we're there. And I know you say, well, we're not there, but we've given them these referral options, and maybe we have a single point of access like in Butte County. It's so much better when you're 10 feet away, right, than a referral option. And I hope we can hold that out as tangible and as possible, instead of as some gold standard pie in the sky possibility. Again, that hopefully if we can do it in a place like the Bronx with the complications that we face, then we can hopefully do it most anywhere. So I'll leave you with that and certainly take questions along with everybody else.